Essentials of Health Information Management, Principles and Practices, 2nd edition, Chapter 4, the Patient Record, Hospital, Physician Office, and Alternate Healthcare Settings. In this presentation, we will talk about the medical record as well as different concepts related to that record, especially in terms of documentation, length of retention, and so forth. When we look at the medical record or the patient record, the purpose of that record is for documenting patient care. It also serves as the business record for legal type situations. It also serves for continuity of care. And when we talk about continuity of care, we are essentially saying that it helps the different providers on that continuum of care to communicate with one another to provide continuous treatment for that patient. So therefore, the record is a communication tool. There are also secondary purposes of that record. Our primary purposes deal with that of treatment of the patient, but then there are secondary purposes. For instance, a record is used for evaluating quality, also as a means or foundation for reimbursement. And as I mentioned a few seconds ago, we also use it for legal purposes. We use the record for clinical research and healthcare statistics. These are some of your secondary purposes. Patients themselves can also use the record. They come in and request access to their record. This is considered a personal use. And then you can have user requests for access to randomly selected patient records, and we call this impersonal use. Now, there are different types of records that kind of is associated with the different types of facilities. So you can have inpatient records, you can have outpatient records. And we talked about the difference between the two, one being acute care, ambulatory care, and with those different types of facilities, they all have a healthcare record associated with them. Now, there are similarities to those records, and there are also differences based on the type of patients they see, the type of treatment they provide. This causes the variation in the records. What we see in terms of a trend is that your outpatient records sort of taking on a new type of importance, and they are increasing in volume because of our efforts to decrease the amount of inpatient acute care that we put out. Because we talked about in past presentations the acute care being more expensive and intensive, and so now we look more to providing care that's at an appropriate level for patients. And so with that being said, there is a decrease in your acute care type treatment or visits, and so we, in turn, there is an increase in our outpatient. So the record sort of follows suit. So our record it documents treatment, it holds or stores information that we use to support diagnosis, to justify treatment, to record results of our treatment. And there are different types of information that we find in that record. You have demographic information or data that's in that record, and that is that information that identifies the patient, like the date of birth, their social security number, and what have you. Also, to note about the record, each page in that record needs to include identification information, For instance, like who is their provider or their physician who's over that case, the patient's name, the patient number, date of admission, so forth, and the facility information. Your Medical Records Institute, MRI, categorizes your healthcare documentation as either capture or report generation. When we talk about capture, we're talking about them recording that information in their record, and there are different ways that we can do that, through speaking, typing, or so forth, touchscreen, that kind of thing. And then report generation. We take that information that's being recorded and stored in that record, and we format it in such a way as to generate a report. And that report, we gain knowledge on and direction on the ways we need to do things. Your Medical Record Institute also had what we call the essential principles of healthcare documentation. We're going to find that documentation is extremely important. The documentation, it said, with the requirements for that documentation, there should be a unique patient identification. So that kind of goes hand in hand with our medical record number. There's got to be a unique way of identifying each of those patients. Not only that, that documentation needs to be accurate, consistent, complete, timeless, interoperable, meaning it can go across different systems so that they can share that information, with the ultimate thing of being accessible at the times that is needed. And we can't forget that the documentation has to be kept confidentially and secure. Some of your information has to be transcribed. You may find, and we use what we call medical transcriptionists who do that. They listen to the dictation and they type out the report, right? And the provider then takes that typed out report and reviews that for accuracy. And depending on whether it's a paper record or a electronic record, is either going to be filed in the paper record or it's going to be scanned into an electronic record. You have certain documents that are typically dictated and transcribed, like your HIM, the discharge summaries, your consult, and those types of things you tend to see being transcribed. Ownership of the record. What we need to understand in terms of ownership is that the record is really the property of the provider in that facility. The patient is the owner of its content. And so with that being said, the provider is going to maintain those original records. However, that patient can come in and request access to that information. The provider is also going to be responsible for retaining the minimum data elements required for that original record. When we look at the inpatient and outpatient record, as I mentioned before, you're going to see some similarities, but then, of course, there are going to be some differences. When we look at in terms of your inpatient record, that record begins in terms of when that patient is admitted to that hospital. And once they're admitted, then the record forwarded to the nursing station is where it's usually kept. And that's where all your other providers who are treating that patient in a hospital will then get that record and document based on the type of treatment that they're providing. Sometimes you may see, especially in an inpatient facility who is electronically inclined, they may have what we call those WOWs or COWs, those computers on wheels, in which they wheel around to the bedside and they type in your documentation and information right at the bedside. Your inpatient record is typically about 60 to 100 pages. It's going to be quite larger than your outpatient records, simply because your patient stays are tend to be longer and more detailed, and the type of condition that they're being seen for is usually a lot more intensive. So you're going to see an average size be quite bigger than your outpatient. There is administrative data and clinical data in a record. Your administrative data will include your demographic information, financial information, socioeconomic information, and then your clinical data will be all the information that's obtained through the treatment of the patient. With your outpatient record, we also call it an ambulatory care record. You know, that's for all your outpatient facilities like your emergency department or your ambulatory surgery. The physician office record, they also include administrative and clinical data, as does your outpatient, as does your inpatient record. And what you may find with those, depending on whether it's an independent practice or a group practice, in terms of structure, there may be a difference in structure where your group practice record may be a lot more formally structured than independent physician practice. You also have your alternate care settings, and they have administrative and clinical data as well. But as I mentioned before, you may see, you are going to see some differences based on the type of patients and the type of treatment that they are providing. But all of your records are dependent upon, they don't just come up with things out of the blue in terms of how the record needs to be formatted, what type of information needs to be collected, but it is formulated based on your different accreditation standards, your state and federal regulations, Medicare conditions of participation. All those types of things do have an effect or impact on the way we do business in terms of our records and how they're structured, how they're set up, the things we collect and store. Your book actually gives you an example of some of those differences. It's, for example, with your home health care record, they have what we call a certification and plan of care form that they use for home health services. This will be a document that you won't find in your inpatient record or your physician office record because it is directly related to your home health services. So that's an example. So this is what we mean about the different variances in those records based on the type of treatment they provide. Your Table 4.1 in your book also gives you some good examples of administrative data versus clinical data. Table 4.2 in your textbook, I also like to bring your attention to. It shows you the different types of clinical data that you will find in those different healthcare settings, really highlighting some of those variances. Now, there are also responsibilities in terms of documentation, how things are documented in the record. Your Joint Commission says that only authorized individuals should make entries in your medical record. And HIIM says that only those who are credentialed or have the authority and the right should document their record, and it should be laid out in the organization's policies. Your healthcare providers have the main responsibility of documenting in that record based on the treatment that they are providing, and those documentations have to be in compliance with your accreditation and your different regulations and your legal standards and so forth. Everything that is done to that patient has to be documented in that record. That record is going to support anything that we do to that patient. If we do not document correctly or poorly, then this indicates that we have poor health record delivery. We can also have some issues in terms of legalities and other things based on not documenting correctly. We follow the adage, if it wasn't documented, it wasn't done. This is going to pervade everything that we do and all the purposes of that record. For example, if we don't document something, whether it happened or not, we can't code it in terms of a medical coder. A medical coder can only code things that are documented in the record. Therefore, with that being said, the third party care can refuse to pay. We are going to lose in reimbursement. This is just one of the examples why we have to document everything. Authentication is important. Authentication simply means the author signed that entry. All right? Only the author of the entry can authenticate that entry. When they authenticate or sign, they are saying this is correct, this is true. They are verifying that entry. And per guidelines, they have usually you have to authenticate an entry within a certain time period. Authentication can come in many methods. It could be in terms of some kind of code they put in. If it's electronic, they can sign like a written signature. They can use signature stamps, fax signatures, initials, and so forth. But there are guidelines that affect the way that needs to be done. The other thing that is important is that they have to authenticate it after it has been entered. So in terms of transcription, with the transcription, as your book brings out, somebody may want to, once they want to authenticate it after they have dictated, but it has to be authenticated after it has been transcribed, because they have to verify that everything that was typed or transcribed is correct. So it will be inappropriate for them to try to authenticate it before that has occurred. Now, when we talk about the actual authentication, what needs to be included? So there's a minimum. They need their first initial, last name, and their credentials. But the organization policies can be stricter than that and require something more extensive than what I just mentioned. You also have situations where counter signatures are appropriate. And basically with a counter signature, what that means is maybe someone signs it, but the original, the person who is the actual supervisor of that patient has to come behind them and sign it. You'll see that a lot in terms of, say you have a physician resident, maybe a physician during his residency, and so they will have to have the actual overseeing physician to countersign, so that resident may sign, but then that physician has to come in a certain time period and countersign that. You may also see that with nursing. Maybe they sign something, but that physician has to come behind them and countersign. All right. You will see counter signatures in terms of telephone orders and voice orders, and a lot of times in your documentation, in your record, you will indicate they have TO or VO beside them. So the doctor maybe telephones in an order, and the nurse documents that down. She signs it. Then the physician has to come in a specific period of time and make sure that they countersign that order. A voice order is a verbal order in which that physician is going to dictate that to whatever particular nurse or person, and then they have to actually countersign that as well. And there should be organizational policies in place as to what that time frame is. Also, the verbal order must include the date and the name of the individual who gave, received, and recorded and implemented those orders. Your book tells you that commonly that's a 24-hour period for that documentation, but there have been some issues with the counter signature policies and what goes on with those, so some organizations may not even allow that. You may find organizations that have what we call a signature legend. So basically, a provider may be allowed to authenticate an entry with their initials, but then there's a signature legend somewhere that the facility maintains with their full signature on it and is associated with those initials. Fax signatures, facilities can accept them as well. And a lot of these things, it depends also on your state laws that may prohibit some of those things, so it just kind of depends on where you are. but in certain states they will allow fax signatures. But the thing about a fax signature is you have to have available to you the original signature somewhere, okay? Then you have electronic signature. That's another way to authenticate, especially with the advent of these electronic records. There are different ways that you can use an electronic signature. It ends of email messages, maybe a digitized image of a handwritten signature, a PIN number satisfying or acting as a signature, or some kind of biometric identifier. You can also have your digital signatures that use those cryptography, where they have those two keys, where one key is for creating a signature, and then they mix it up into some kind of babble, and then when it gets to the other key is going to unbabble or mix it up so that it goes back to its original form once it reaches the receiver. So that's another form that they can use. The American Society for Testing Materials, ASTM, has authentication guides in terms of defining those authentications, telling you you need to have minimum requirements for your electronic signature mechanisms, acceptable electronic signature mechanisms, minimum requirements for user identification. So they just provide some different guidelines to complement standards that are developed by your other organizations or other organizations. Signature stamps, they can in certain states be accepted, but the signature stamps you have to be very careful with. They are a less secure method of authenticating, simply because, well, usually what they do, if they allow providers to use the signature stamps, they have to sign something that they're going to be the only ones using that stamp. They can't go and let other people stamp things for them. And so there's just a big, a significant area for misuse or abuse of your stamps. So a lot of organizations and entities do not allow providers to use the signature stamps. But they have to have, if they're going to use them, they have to be strict policies and procedures on that in the organization. And your book also brings out that Medicare does not allow the use of signature stamps or date stamps on their certificates of medical necessity for durable medical equipment. So in that area, Medicare doesn't allow. So, but that is another possibility. Then you have abbreviations. I know there are a lot of facilities, especially like on your HMPs or your histories and physicals and in your discharge summons, don't even allow abbreviations to be used. But if an organization allows some type of abbreviations, they have to have a policy on those abbreviations, acronyms, and symbols that they can use in that record, and they have to have an official abbreviation list. If there is acronyms that have more than one meaning, then those are prohibited. Your book on Figure 4.7 gives you a sample example of an official abbreviation list for a hospital. Legibility is also important in a record, especially in your paper record. That tended to be a significant problem with physicians not knowing how to write, and it's hard to understand what they're writing, and that can lead to a lot of errors, medical errors. So legibility is important and required. Your electronic health record sort of helps solve that problem, because now we don't have to depend on handwritten documents and progress notes and what have you. Now we can have that computerized or typed. The timeliness of patient record entries is also important. The guideline or the rule of thumb, you want to document in that record as soon as possible after the actual treatment or event has occurred. For example, your conditions of participation, which is put out by Medicare, the physical exam, they require that physical exam be performed no more than 7 days prior to admission or within 24 hours after admission. So they actually apply time frames to the physical exam, and there are other examples of that. it states that the report for the physical exam, still talking about your military conditions of participation, the report for that physical exam has to be put in our patient record within 48 hours after admission. So time frame is important, right? And the thrust behind that needs to be done soon as possible. The Joint Commission says that your patient records need to be completed 30 days after that patient has been discharged. This is very important, and they do push this, implement this, because once 30 days has passed, if things are still missing in that record, then that record becomes delinquent. There is a delinquent record rate that is kept, and we have to be below 50%. And you get your delinquent record rate by dividing the total number of delinquent records by the number of discharges in that period. And so we keep up with that, and preferably you want that to be under 50% according to Joint Commission. Now, there are times when a patient may want to amend the record, or the author needs to amend the record, but there are requirements and guidelines in terms of amendment. The only person authorized to correct the entry will be the author of that entry. So in order to amend that, then what we need to do is to draw single lines through your incorrect information, but you got to still be able to see the original information, use date and time, and sign that corrected entry. And you got to put the reason for the error in a location that's close to your original documentation. And then you're going to enter that correct information as close to your original information as possible. The thing here is when you make any changes of that nature, you cannot totally obliterate the original information. You still have to be able to see that information. If they are trying to correct a transcribed report, your book brings out that if they edit that prior to authentication, they must also follow a version. They have to follow the version of that previous procedure we talked about. If they redictate it after the original report has been filed, then they have to keep on. They have to maintain both the original and the redictated report. They draw a single line across the page of the original report, write redictate it, put down the reason for that, date, time, and sign it. And then the redictated report, then the provider will authenticate that after they review it. Now, if you use an electronic health record and you need to correct errors in that, it kind of depends on what type of information it is. But the thing about it is they have to store both the original and the corrected entry, and they still have to document the date and time of that authentication, reason for the change, same kind of thing, except for you just in an electronic environment, and you still follow that you can't totally get rid of the original, even when you make changes. But one thing about your electronic record, they use what we call audit trails, so they are able to see all the transactions that are being done or activities that are being done in that record, and that's something that the paper record is not able to do. And so that's one way that you can control that type of situation. You also know that HIPAA gives patients the right to come in and want to ask for amendments in their records or corrections, but the provider has the right to deny the amendment request. And if that's the case, an individual can still submit a written statement to clarify some information that they feel is not correct in their record. Of course, HIPAA is also provides rulings on us and governs the privacy, security, and your electronic transmission standards for your healthcare information. And they do mention or address those addendums and how that information needs to be clarified in those addendums and what individuals' rights are in terms of that. All right, so you have your addendums that clarify the information, in which they're not actually changing, they're just adding some information, or you may have what we call a late entry, where you put in information that's out of sequence, which is providing additional information. And you want to do all that, even if you have an addendum or a late entry, you want to do it as soon as possible after the original entry. You don't want to wait too long. Your book provides your steps in terms of doing that. You have to document the word addendum or clarification or late entry. Give the current date and time, as well as the date and time of the original entry, so you can reference that. Then you're going to authenticate it and state the reason for documenting the addendum. Provide any supporting information that provides that clarification. Enter your current date and time. You don't want to make it look like that the additional information was placed at the time of the original entry. This would be improper. Even if the facility is reviewing information and finds out that something is missing, you cannot change your original entry as if that was added all at the same time. Again, this is improper. In your slides, this provides a pictorial example of your signature stamp. That's also in your book in Figure 4.6. And here's an example of the abbreviation list that we were discussing. That is your Figure 4.7 in your textbook. Same pictures. All right. So your record. We're talking about the record and how it is created and all the way to discharge. And a lot of times we talked about the inpatient record and its beginnings in the admissions department. However, it actually can begin before the admissions department. They have a lot of your inpatients have what we call PAT, pre-admission testing, basically where the patient is sent out before their admission to their hospital to maybe get some tests ran or some other types of services. And this kind of facilitates the treatment and reduces their length of stay. If they get a couple of things that they can get done prior to admission, they get it done. So actually, if that happens, then your record will start there. Okay, so, you know, anesthesia, pre-anesthesia screenings, all those types of things. Maybe they need an x-ray. Your book brings out these things they may have them do ahead of time. But this will start so that means essentially that the record started before admission. All right. Now you also going to have patients coming in from your emergency department, then your record will have started in the emergency department. But in a traditional sense, your records start in your admissions office, unless you have the PAT or the emergency department. They're going to collect demographic data on that patient. That's going to start the record. A lot of your demographic information you will see on what we call a face sheet. That's usually that first sheet in the record that lists that demographic data, what the physician's name is, what they came in for in terms of a provisional diagnosis or working diagnosis, tentative diagnosis, whatever you want to call it. That'll be all on the face sheet. If they have an electronic health record, then they have that first screen that sort of acts like your face sheet, mission screen. Then you have consent forms that are included. It's usually toward the beginning of the patient's admission, where they are consenting to treatment. You got other consent, general consent forms for admission, in which HIPAA has already described that facilities or organizations are not even required that they have to obtain admission consent, but a lot of your facilities still do so. The other special consent forms are signed maybe to specific types of treatment, and then either the patient signs them or their legal representative will sign those forms. After they finish up with the admission process, then when that patient is on the floor, the nursing floor, then that record goes to the nursing unit, and from there the nurses complete their initial assessment of that patient. They're looking at a patient's history, current medications, and so forth, everything that helps the nurses to carry out their responsibilities. Also, physician orders that are in there. Your attending physician, again, is responsible for the H&P, or your history and physical examination. And you know they can be written or dictated. And then, after all that has occurred, then you have all your other types of providers. Maybe it's the dietitian, the therapist, whoever else that patient is seeing while they are in that hospital, who are going to document in their record. So all these things are added to their record. Any surgeries they have, then you're going to have an operative report and those types of things that's in there. If they go to some of your ancillary departments and get an x-ray, labs, or what have you, those reports are also placed in the record. Now, at that point in time, when it's time for that patient to be discharged, then your attending physician is going to dictate that discharge summary document. Your discharge summary is just that, a summary of that patient's entire stay in that hospital. What happened during that course of treatment, what's that patient's condition at discharge. Then you have all your other departments, like your nursing, whatever, that also have, they document summaries in their progress notes. You have the discharge instructions that are placed on chart, where they discuss with the patient's family, different things they need to do in terms of discharge, what they need to do post-discharge, do they need to follow up with their primary provider, and those types of things. Now, there are different types of orders that you can see in a patient record. The one that's most common is your reverse chronological date order, where your most current document is at the top, and your the document that's the oldest will be at the bottom. This really facilitates documentation, because your providers are going to be, your most accurate report is going to probably be your most recent one, and that's where they document. Now, discharge patient records are typically organized in chronological date order, but you have some instances in different, and I might mention that different healthcare facilities do their things different ways. This is just common things that they're talking about, so you can work at one that does not do theirs in this manner. But you may have, once upon discharge, the record goes into a different order. So your discharge order might be different from when the record was active. And here they're saying the common thing is your active records are in reverse chronological date order, and then your discharge records, then they're changed into chronological date order. You have some facilities who do it the same way for both inpatient and discharge, which is called your universal chart order. With that saves time, because I've worked in places where the order is different. And so what happens is, once that patient record is discharged, the HIIM department has those records, discharge records, delivered to them, or they pick them up from the nursing floor. And if your order is different, then we take them out the hard binders and we put them in your paper type manila folders, and we change the order. So that is a little more work intensive. When you have outpatient records, they're going to be handled a lot more frequently, just based on the patients frequently visit the the physician office more so than they would a hospital. Hence, you're going to have a lot more traffic in terms of moving and opening, going back in those records back and forth. Now, there are different formats for a record. And we talked about primary and secondary. So you know your primary source of information are the information on records that are documented based on your actual patient care. So that would be like your out reports and things like that. And then your secondary sources of information are information that's abstracted from your primary source. So that would be like your master patient indexes, your incident reports, your different registries. An incident report basically is a document that collects information about different incidences or errors or injuries that occur at a facility. It can be collected on patients as well as visitors. The one thing you need to know about an incident report is that you do not file it in the medical record. It is not filed in the medical record. It is filed with the risk manager's office, but you do, if there is an incident that occurs with a patient, you do document the facts of that incident in the progress notes of the record, but you do not make reference to the incident report, nor is the incident report filed in that patient's record. The incident report is internal use. It also, your healthcare facility attorneys use those, and you don't put it in the record, because if it's in the record, then it is open to be requested. Once if it's accidentally put in the record, then if that record is subpoenaed, then that information will go to outsiders, but that's not what that is for. They try to use that to minimize risk, as well as it's information accessible for your attorneys and whatnot in that situation. Now, in a paper record, there are different formats that a record can be in. In an electronic record, you can put you can put that information in all types of formats. That's the beauty of an electronic health record. But if we're using a paper-based record, you can actually have it in what we call source, in the format of source-oriented record, or SOR format. You can have a problem-oriented record, POR format, or integrated record. If you have your documents maintained in a source-oriented record format, basically what this says is that your record is divided according to departments, which would be equal to source. That's what we mean, source, so your department. And each department will place the documents that they generate into their section of the record. Therefore, it's also known as a sectionalized record. So, for example, if you got nursing notes, they're going to go into the nursing section of your record. All right. If you have a physician order, it's going to go into the physician section of the record. If you have case management notes, it's going to go into the case management section of the record. So, source-oriented record is the documentation is placed in the record according to the source. If you have a problem-oriented or POR formatted record, it consists of 4 components, and it's organized based on the patient's problems. You have the 4 components will be the database, the problem list, the initial plan, and the progress notes. Your database, it contains a minimum set of data that's going to be collected on every patient. So basically, like the chief complaint, their past history, review of systems, their physical exam, those things are going to be collected on every patient. So we call that database. The problem list is like a table of contents, which it lists all of the patient's problems or conditions that they have, and they number each one of them. If you look at figure 14 in your book, it gives you an example of it. You see the database at the top, and then toward that middle, you see the problem list, and the problems are all numbered, dated. You see the problem description, and then there's also a column for when those problems are resolved. When the new problems come up, then they just add that new problem to the list. They update that list, assign a number to that new problem. Then you have your initial plan, which describes your actions that you're going to take based on what that patient's problems are and how you're going to treat them, educate them about those problems and that type of thing. Now, in a problem-oriented record, the notes are going to be documented in what we call a SOAP format. And so when they collecting those notes, SOAP stands for Subjective Objective Assessment Plan. And a subjective is basically the patient's statement on what's wrong with them, right? So that's subjective. They are describing their situation to that provider. Objective is what that provider is observing about the patient. And then assessment is that provider making judgments or evaluating that patient as to what the actual problem is. And once they figure that out, they can construct a plan to resolve those problems. So that's SOAP, Subjective Objective Assessment Plan, which is a document structure for the notes. The discharge summary will be in the progress note section of your problem-oriented record. If they have going to transfer to another facility, then you also will see transfer notes documented in the record as well. Now, integrated record, this is one in which everything, all the things we discussed is kind of pulled together into one. We don't have anything separated out. The reports are in a strict chronological date order, so it does not matter what department it's generated from, what problem it is. It just kind of reads like a story, right? They have a first, second, third, and we just keep documenting in that form. Okay. Now, basically, with your I think I done jumped out above these. So I've already talked about your automated record systems, but being that they can display in any format, and so that's a very direct advantage, because basically depending on what you are trying to do for your patient, maybe at some point a source-oriented record is better suited to your needs, and then at times maybe a problem-oriented record, or maybe a integrated record or some other format. So your computerized, your electronic health record has a distinct advantage in terms of that versus a manual. But one thing it is to note is that sometimes paper is better for certain activities. So your electronic health records and your systems are not meant to just totally delete papers out of the process, but the electronic health record is here to create a more effective, efficient process. Now, in terms of your records, as a facility is continually seeing patients, there are going to be some parameters, especially if they're dealing in paper-based records, more so than electronic records, where you're going to have, say, your the amount of room you have in a facility is going to place some restraints on how many records that you can keep on site. Also, there are different laws and rules and regulations and accreditation standards and different things that weigh in on how long you need to keep certain records. Also, what your needs are as a facility in terms of what you need to do with those records also places parameters on how long you will keep records. In the event of that, then you're going to have some what we call archived or inactive records, and you're going to have active records. You end up having archived records, especially if with paper format, when you don't have so much room to keep records on site, but then maybe it does not meet the record retention laws, then you're going to archive records. And so your organization will have policies on that, on how long you're going to keep those records, how we're going to store those records off. You might store them off-site. Some people may have something in a basement or something where they keep archive records. They may outsource that to another company. HIIM1000 would be an example of a company that stores. I know I've worked at places where we store our medical records at HIIM1000 in Jacksonville, and we will order those records if a patient or someone comes in and requests access in an appropriate manner, then we will have to order those and they ship them to us. So that's one means. Some people digitally archive those records, maybe put them on, scan them in somewhere, or put them on some type of imaging thing in order to store those archive records. You also have what we call shadow records, where they are just copies of your original record that they maintain somewhere else, or they have a copy that they maintain somewhere else, whether it be in an electronic format or paper format. There should be policy based on those, on how that needs to be done. But your book brings out that your electronic health record can solve some of those issues where you may not even need a shadow record or independent database, and where all that information will be available to all your healthcare professionals at any time. And therefore you wouldn't even need that. So that's something that an organization can look into. Now, in terms of your record retention laws, of course, an organization has to keep those records in compliance with whatever your state and federal laws are in terms of record retention. And then if you are an accredited facility, you have to also make sure you satisfy or in compliance with whatever their standards are. However, their facilities can have a more stricter policy where they keep them even longer than is outlined in any of those I've mentioned above. Based on the cost of storing those that has to weigh in, as well as what their needs are. Now, some may opt to purge their records once it has been beyond those, once they have satisfied those record retention laws, they may opt to purge them. Or some, if they have adopted an electronic health record system, decide they want to keep those indefinitely. Your book brings out some different regulations and standards put out through Medicare, like in terms of their conditions of participation. They say that hospitals, long-term care facilities, specialized providers, home health agencies will have to retain their records for a period of no less than 5 years. OSHA weighs in. That's your Occupational Safety and Health Administration. There's employee records. Who have worked for longer than 1 year have to be retained for 30 years. So all of these have these are examples of different entities that have guidelines and regulations as to how long records must be kept. Your HIIM recommends a minimum of 10 years for your operative indices and operating room register being maintained permanently. Also, I know a lot of your entities, like your HIIM and some others, sometimes stipulate when they talk about the age of majority. Say you have a patient that is a child, and they tell you have to maintain that record to the age of majority plus 10 years, which means basically to the age of consent plus a 10-year time period. So when the patient becomes 18, you have to maintain that record 10 years more. The thought concept behind that is that once the patient reaches the age of majority, then they can perhaps make some decisions about their healthcare record that they could not as a minor. So you have to pay attention to your retention record laws, and especially in an organization when they're developing policies about how long they're going to keep records. All of those things weigh in on a facility retention policy. Your book sums it up nicely into bulleted points there on page 94, that you have to consider your accreditation recommendations, your federal retention laws, your legal requirements, your need for continuing patient care, research, educational uses you may have for your record, and state retention laws all weigh in. So you can off-site storage, which I've already talked about, but you have to make sure when you're dealing with other vendors, they still are have to follow your different regulations in terms of confidentiality. You have to see what their policies are on different things, because you still will be held accountable. So you have to negotiate that contract as well as look at how they are going to handle those safeguarding procedures. You look at cost, are they secure, how the records are going to be transported back and forth, and how are you going to access those records. All this has to come in to consideration. Now, an organization can decide to put things on microfilm, but they got a lot of more exciting technology for storing. And microfilm, they have a picture of that for you in Figure 412 and Figure 413, page 96. This probably reminds you of when you go to the library and look at those old newspapers and stuff on microfiche and all that kind of stuff. And then you have optical imaging that can be used. So there are different methods that an organization can use if they need to store those records. And a lot of the electronic things that they have now, it takes a lot of that physical space out of the picture. You don't need all of that as if you would with paper records. Now also, you have records. Once you keep those, say if you're not deciding to keep those things indefinitely, then you may consider record destruction methods. And basically with your record destruction, you're saying, well, I have kept these in compliance with my record retention policies and laws, and now we're going to get rid, we are going to want to destroy these records. It doesn't matter what format, we're going to get rid of these. And there has to be policies and procedures put forth in your organization in terms of how we're going to do that. So there has to be what we call a record destruction policy. And once you destroy those records, you have to have what we call a certificate of record destruction. If you look at figure 414 on page 97, there is an example of a certificate. And if you're looking there, you see that it has the dates of the records that you're going to destroy, what types of records you're destroying, how the retention of them, the method you are destroying them, who is authorizing it and certifying it, and you have your records management officer, your health information manager who signed on it, and your file area supervisor that signed on it, and you mentioned that they were destroyed in the normal course of business. Your certificate of record destruction is going to be permanently maintained at your facility. All right. When you destroy records, you have to destroy it so that they cannot be reproduced. All right. And so they have different types of destruction methods for different types of records. For a paper record, you see here, you can shred them, you can burn them, you can pulverize them into powder, all those things. If you have automated records, you can use magnetic degaussing, you can overwrite data on them. Microfilm, you can use chemical recycling processes. So the basic point is once it's destroyed, no one can come behind you and recreate anything. All right? And your book brings out a note there on page 97. When you're destroying your computerized data, you have to also destroy any backup information that you have maintained. Okay. Other things when we're looking at record responsibilities, you also have to make sure, say, if a facility is closing or being sold, the responsibilities for that information does not cease at that time. They have to still maintain the confidentiality of that information and have to handle that according to your federal and state laws. A lot of times what you see, if the facility is actually closing, then the state, the health department takes over that information, or if a practice is being sold, then the new owner takes over the records from the old owner, and then letters should be sent out to your patients so that they know what's going on with their records. There's also responsibilities by the different areas of your organization in terms of patient record completion. Say, for instance, your governing body that's mentioned here in your book. What their responsibility is that they're going to make sure that that patient is getting high quality care and that care is being documented appropriately and completely in their record. Whereas your administration is going to make sure that they enforce those rules and regulations set out by that governing body, and they're going to enforce those rules, regulations, and policies. Your physicians, they have a very big and significant responsibility because they are the ones who are actually documenting all of your information in their record, and so they need to make sure that that information is complete in that record, and that it is also timely per the different regulations and parameters set out through our different federal, state entities, our accreditation entities, and so forth. In terms of the health information department, the manager there, we are responsible for making sure that everybody else knows or is educated on the proper documentation policy. We're also going to assist them in designing the patient record systems and making sure that everyone is in compliance with any of our state, federal laws, and facility policies. We ensure the quality and completeness of that record. When we do record assembly analysis in the department, basically what we're doing is once those records are discharged, and we talked about the different record orders for active, for inpatient versus discharge record, discharge patient. Those discharge records become our purview after they have been discharged, and so we assemble those according to whatever order is outlined in the facility policy, and then we're going to analyze those records. So what are we doing when we analyze? We got different types of analysis here. We got quantitative, qualitative analysis, concurrent analysis, and statistical analysis. When we're analyzing that record, we're looking for deficiencies in that record. Is this record complete? If it's not, then the record has deficiencies. Those deficiencies, we have to notify the providers who are responsible for completing those deficiencies. We can mail a letter to them. We can put something in their mailbox at the facility. We can call or email those providers so that they can complete those deficient records. We complete what we call a deficiency slip. The analysis clerk completes that, and then they file those records in the incomplete record file area. This is where those providers can come in to that incomplete record file area and take care of those deficiencies. Your book brings out a good point, which I hadn't personally thought of before, exactly because I've been in certain facilities where they file those incomplete records in that incomplete file area based on providers. However, what the book was bringing out was that if you file them by the record number versus by provider, then all of those providers, say there's a record where 2 or 3 providers need to correct a deficiency. If you do it by record number, then they can come in and just pull those records as needed, and multiple people can use that record base versus you have them all in one doctor's section, and then it's only in his section. So that was something that really stuck with me there. But basically, there's a process put forth in order to satisfy and complete those deficiencies. We already talked about we don't want delinquent records, so this is that process that an HIIM department puts in place to get those records completed. And remember, we talked about they have to be completed within 30 days. So once they have the deficiencies the provider comes in, corrects those deficiencies, then we reanalyze that chart to make sure that those deficiencies have actually been corrected. If they have, then we go ahead and store it in the permanently filed area. If not, then they go back out to get those deficiencies corrected yet again. If it's in a electronic record environment, the same thing can occur, but you tend to work with work queues or something of that nature where they go in to the computer and handle those deficiencies. And the good thing about automated chart completions is that they can generate deficiency reports. You can see your different physicians or providers who are always have deficiencies. You can see what type of deficiencies you always have, so those reports can be very informational, and that's a benefit of having a computerized automated chart completion system. You can have concurrent analysis or retrospective analysis. Concurrent analysis is when we analyze those records or review those records while that patient is still being hospitalized, versus retrospective analysis is when we analyze those records after that patient has been discharged. Qualitative analysis is all included in our analysis. When you talk about quantitative analysis, we're just checking for completeness of that record. Qualitative analysis, we're looking for inconsistencies that may identify incomplete or inaccurate documentation in a record. Statistical analysis, we are abstracting information for that record for us to make decisions upon. Okay, so all of that flows into part of the role of your health information department. Now, the other thing about that, so we send out those letters and to the physicians to come handle their deficiencies. They don't do that, then there can be suspension letters that are sent out to those physicians. They may have be penalized through the facility, although that often does not occur, and that can be very frustrating that your administration really doesn't enforce some of the suspensions that they say they're going to put out there. But that's just reality at this point. Okay. That's going to complete our discussion. Before I close all the way out, I just want to bring your attention to figure 415, which is the actual example of a deficiency slip. Now, different organizations may not look exactly formatted this way, but you're going to see some of the same content in terms of the deficiency slip. This is the last concept that we're going to cover. This is going to complete my presentation on Chapter 4.